Welcome to the second episode of AngioPod, the podcast for vascular fanatics. I'm here with Dr. Singh, Ara, and Zach, and today we're going to talk about atherosclerotic carotid artery disease. This is going to include landmark papers on carotid endarterectomy, carotid stenting, and all you need to know about managing carotid stenosis. Let's get started. Ara, tell us what are the indications for carotid intervention?
So there's two categories of patients that we look for, symptomatic and asymptomatic. For the asymptomatic patient, it's usually stenosis greater than 60% with a life expectancy of 3 to 5 years. And for symptomatic patients, it's usually stenosis greater than 50%.
Dr. Singh, what are some of the landmark trials that this data is based on?
Okay, so there are several trials, but we can be here all day covering all of them. So let's talk about the ones that are most often asked about. So for symptomatic patients, typically we're asked about the NASCET, N-A-S-C-E-T, the NASCET or the North American trial. And the other one is the European, the ECST. So let's talk about the NASCET first. So the NASCET trial showed that there was a benefit of carotid endarterectomy in symptomatic patients that were from 70 to 99% stenosis. There was a significant benefit. Patients less than 70% that were symptomatic, the benefit was only modest. Now, if you're asked some numbers, actually, AJ, maybe you can answer this for us. The attending will often ask you, well, what's the risk of reduction or what's the likelihood of stroke in these patients? So symptomatic patient, what did the NASCET tell us about risk of reduction?
So again, for high-risk stenosis, more than 70% and 2-year time period, between the two groups, that's medical management versus surgical, the risk of stroke in the medical group was 26% versus 9% in the surgical group. And that brought the absolute risk reduction to 17%.
Okay, very good. So moving on to the second symptomatic trial, which is the European, the ECST, we'll call it the European trial. So the European trial also showed that there was a benefit of endarterectomy in patients with high-grade stenosis. However, they only showed benefit in patients that were greater than 80%. Patients less than 80%, they did not show any significant difference. And essentially what they showed that there was in the medical group, 16.8% risk of stroke in 3 years. In patients that had surgery, 2.8% risk of stroke in 3 years. So that means a difference, an absolute risk reduction of 14%. But again, this is only patients with greater than 80%. Also to mention, the NASCET criteria, when they looked at the degree of stenosis, they based it on angiography. The ECAS study or the European study, they looked at duplex findings. Let's move on to asymptomatic. The most often asked about study for asymptomatic patients is the ACAS study, or the ACAS. So this study really looked at patients that were asymptomatic and whether there was a benefit of surgery in asymptomatic patients. And they looked at a 5-year time period. AJ, what did they find?
So the ACAS study used a degree of stenosis of 60%, and over the 5 years follow-up, they found the rate of stroke to be 11% in the medical group versus 5.1% in the surgical group.
So basically that brings your absolute risk reduction down to about 6%. So if you look at the two studies, the asymptomatic, the ACAS versus the NASCET study, you see that there is a bigger benefit in patients undergoing endarterectomy that are symptomatic.
Ara, let's say you have a patient that recently had a stroke, is admitted, and you get consulted because they found 70% stenosis on the duplex. When would you offer this patient intervention?
So the current SVS guidelines is optimal timing for surgery is usually less than 3 weeks after a fixed stroke. And for patients with recurrent strokes, the highest risk is in the first 2 weeks after the stroke.
Is there any clinical situation where you'd like to offer the patient emergent carotid endarterectomy?
So the indications for emergent endarterectomy is for patients with crescendo strokes. These are recurrent TIAs with complete resolution between each episode.
Okay, Ara, so for a patient with crescendo TIAs, would you stent these patients or would you perform an endarterectomy? What do you think is more preferable?
So you wouldn't want to stent these patients because the plaque is unstable. So the preferred method is doing an endarterectomy for these patients.
Zach, let me ask you something. How would you approach a patient that has carotid artery disease and also has coronary artery disease?
So for patients with coronary artery disease, the following features indicate that they're high risk for stroke. So anyone who's above 65 years old, anyone who has an atheroma in the ascending arch, anyone with a symptomatic high-grade lesion or an asymptomatic lesion above 80% stenosis, or someone with an occluded ICA or previous TIA/stroke. And there are several options for repairing these. You can do a concomitant procedure or a staged procedure. Most surgeons would prefer to do a staged procedure for a patient with stable CAD. If a patient has unstable CAD with high risk factors for stroke, we typically recommend a concomitant CEA cabbage, and this is preferred because it has a lower stroke rate and overall mortality rate.
For our listeners out there, a staged procedure is where you do the carotid endarterectomy before the cabbage. A reverse stage is when you do a cabbage and follow that up with a carotid endarterectomy. And concomitant procedure is where you do a cabbage along with the carotid endarterectomy.
Let's move on to some of the technical aspects. And one thing that always comes up is monitoring. How do you monitor these patients? So a patient's undergoing endarterectomy. What are the options? AJ, you want to take this one?
Yeah. So there are a subgroup of patients that are high risk for intraoperative strokes, and these are patients who have a history of stroke as well as contralateral carotid occlusion. And that's because you will not have an intact circle of Willis to perfuse the cerebral hemisphere in a retrograde fashion. What are the options and how to monitor these patients? You have the option of awake carotid endarterectomy. Again, there's institutional preferences. There are problems with this. You need to have a patient that's awake and that can follow commands, and you have to have an anesthesiologist that's willing to perform this procedure under local anesthesia and provide cervical block. That said, some institutions do prefer awake carotid endarterectomy. The other option that's frequently tested is carotid back pressure measurement. And the way we do this is after you've clamped the external carotid artery and the common carotid artery, a needle or transducer needle is placed in the carotid bulb. This is connected to the A-line tracing monitor, and that will give you the back pressure from retrograde perfusion. If you have a back pressure of over 50 millimeters of mercury, that indicates good retrograde cerebral perfusion. A back pressure of less than 40 millimeters of mercury signifies you are going to have hypoperfusion, and these are patients that you would want to shunt. The other option, and the one that we prefer in our institution, is an intra-op EEG. It's very sensitive. It's a very good test. You get a baseline of both cerebral hemispheres at the beginning of your procedure. Any change from either hypotension or after clamping that you notice on the EEG can be corrected with a shunt. And you can also see your reperfusion because the EEG changes will come back to baseline once you've adequately shunted the patient.
Yeah, just have to remember when you're looking at EEG and what you're looking at is from a baseline, you have a waveform. When you have a 50% reduction in that amplitude of that waveform, that's suggestive that you have a slowing of the waveform or inadequate perfusion. Some of the other monitoring methods include transcranial Doppler. Now, this is not often done because it could be technically difficult. You need a technician in the room. You need somebody to read it. But that is something that you should know. What about shunting? Routine shunting versus selective shunting? AJ, what do you think about shunting?
So again, some institutions routinely shunt all their carotid endarterectomies. Of course, there is some data that has shown a higher embolic stroke when these patients were monitored with transcranial Dopplers. And then there are the issues with shunting. One is if you're not used to it, it can be really hard to sew your patch when your shunt is in place. The other issue is you can dissect the vessel that you're trying to insert the shunt in, as well as cause a thrombosis or an embolic event. The shunt itself can thrombose off, and that again can lead to hypoperfusion. Zach, tell me the role of using a patch in carotid endarterectomy.
So patch angioplasty is actually a level 1 recommendation from SVS. Data shows that you have a decreased perioperative stroke rates and restenosis rates at long-term follow-up when using patch angioplasty versus primary closure. There are several options for the types of patch to use. You can use autogenous saphenous vein. You can use autogenous internal jugular. You can use Dacron, PTFE, and pericardial patch. Amongst patches, Dacron has the highest perioperative stroke rate, but restenosis rates are similar to other patches.
What about some of the complications that are specific to the patch?
The most specific patch complication is patch infection, and this can present as an abscess, erythema, false aneurysm, or even as TIA in strokes with a patch blowout. The most common organism is Staph aureus, and this accounts for above 70%, with MRSA accounting for up to 15% of that, and Staph and Strep together account for up to 90% of patch infections.
How would you manage this patient that shows up with erythema along their neck incision after surgery?
So the most important thing to do is basically get the patient on antibiotics, and if possible, get the tissue cultures done first. You'll eventually need a patch excision and autogenous patch angioplasty if possible. If the patient can tolerate, you can ligate the ICA, but you have an increased risk of stroke for this. You can also do carotid stenting as a bridge to definitive surgery. Other options are patch excision with prosthetic reconstruction. However, if you do this, you have to do a sternocleidomastoid as a flap for coverage.
Ara, this is another one of my favorite questions to ask residents. What if the bifurcation is very high? What are your options?
So some of the surgical options are you could do subluxation of the mandible. This procedure actually has to be done preoperatively with nasotracheal intubation. You could also do transecting the posterior belly of the digastric, as well as the resection of the styloid processes. Most surgeons usually prefer stenting because these procedures are very morbid.
Ara, since you mentioned stenting, Dr. Singh, let's talk about when to stent, what are the contraindications, what is the relevant data out there regarding carotid artery stenting?
Okay, so stenting that's the new hot topic, especially with TCAR, which is now becoming more and more available to surgeons. So the indications for stenting is the same. Stenting is approved for patients that have a challenging anatomy, such as what Ara was talking about, a high bifurcation, which may be surgically inaccessible, radiation to the neck, which makes dissection very difficult, and also patients that are high pulmonary risk or cardiac risk, so high risk for general anesthesia. So these are the reasons for stenting. Now, not every patient can get a stent. There are certain contraindications to stents as well, one being a tortuous vessel. So if it's a vessel where the stent is not going to lie flat, that's a contraindication. Also, if it's a circumferential calcification where the stent might not open up, that's another contraindication. One thing we already talked about, which is crescendo TIAs. Remember, this plaque is unstable. As you pass a wire, you can break off the plaque and cause an embolic event. So crescendo TIAs is another reason not to stent, or unstable plaque is a reason not to stent. Let's talk about TCAR a little bit, I guess, since we are using more and more of it. Remember, if you're going to use TCAR, you need a long common carotid artery, at least 5 centimeters from the bifurcation, where you can go ahead and place your sheath. Also, for transfemoral stenting, a rough aortic arch, meaning very calcified aortic arch, may be another contraindication, and also the type of aortic arch, whether it's a type A, B, or C arch, that may be another reason not to stent.
What about cerebral protection when you're stenting? Because obviously there is embolic phenomena every time you stent. How do you protect the brain?
Very good question. I forgot to mention that. So if you are going to do transfemoral stenting, you must use a cerebral protection device, whatever type of filter you may be comfortable and that may be compatible with the stent. Of course, if you're using transcarotid stenting or TCAR, you don't need to place a filter because now you're using reverse flow. So you're essentially it's essentially retrograde flow.
Dr. Singh, what are some of the studies that the residents and the fellows should know about regarding carotid stenting versus carotid endarterectomy?
So there are multiple studies. You can go on and on. Most of these studies they're essentially non-inferiority studies. They basically show that stents are just as good as endarterectomy, but no studies has shown that a stent is better than endarterectomy. The most common study you're going to be asked about, or the newest one, is the CREST. This was a randomized multi-institution study. They looked at 2,500 patients. They separated the patients and patients that underwent stenting versus endarterectomy. Okay, so the primary endpoints they looked at was MI, stroke, and death. And they saw equivalence in the primary endpoints, essentially the same, carotid versus endarterectomy, 7.2% versus 6.8%. So essentially no difference in composite events. But however, when they did a subgroup analysis in this study, they looked at MI and disabling strokes. And they saw the patients that underwent endarterectomy had a slightly higher rate of MI, 2.3% versus 1%. But when they looked at the stroke rates, they realized that patients that had carotid stenting had a higher stroke rate, 4.1% versus 2.3%. These were statistically significant. One thing to remember is that the MI rates that they looked at also included chemical MI, so not all patients had symptomatic MIs. Some of the other studies I might mention include SPACE, EVA3S study. There's a few more. You should just be familiar with them, but again, we can spend all day here just going through all the studies. But essentially, they showed all the same. These were non-inferiority studies with a lot of criticism.
Dr. Singh, what about restenosis after carotid endarterectomy and in-stent restenosis after carotid stenting?
Okay, so the restenosis rates are typically quoted as approximately the same, about 10% overall restenosis rates. You should know that if there's restenosis in less than 1 year, we often attribute this to, what is this likely from?
Most likely neointimal hyperplasia.
And what if it's more than 1 year?
Atherosclerosis.
That's correct. So this is a question that we all often ask. So you do have to know that. Now, when you're looking at restenosis rates, endarterectomy versus stenting, one thing to remember is when you're looking at the velocities, we typically take a higher velocity compared to a patient that has not had an intervention. In other words, the patient comes to your office and that patient has 70%. What's considered 70% stenosis based on consensus velocities of, let's say, 275, and that patient comes back a year later after he was treated. Now he has velocities of 275. That may not be considered high-grade stenosis. We look at a higher velocity. Typically, anything over about 350 or so is considered high-grade stenosis in patients that's already had an endarterectomy.
And when would you typically offer reintervention to these patients?
Well, you treat these patients, basically the same as any other patient with carotid disease. So a patient that has had an endarterectomy before and they have greater than 50% stenosis and they're symptomatic, you have to treat that patient. A patient that is asymptomatic, however, you were going to treat them the same, greater than 80%. But again, remember, you're looking at a different velocity criteria, a much higher velocity criteria.
So, Zach, one of the clinical scenarios that they love to give on app site, V site, as well as the ports is a patient that you just operated on, did a carotid endarterectomy, and they develop an immediate postoperative stroke. How would you approach this patient?
So the first thing you would do is you do a duplex ultrasound, and you would look for thrombosis of the carotid site. If you have thrombus there, it's likely due to a technical error, and you'd have to take the patient back to the OR and do revision. However, if you're doing the ultrasound and you see good flow, it likely means that there's some sort of embolic phenomenon going on, and you'd have to do a cerebral angiography, a CTA, or MRA. The goal for all of this is prompt reperfusion. You can do this through PMT, which is percutaneous mechanical thromboablation, and this is for distal embolization, or chemical thrombolysis using TPA. However, if there's thrombus there due to technical error, like I said before, you just have to take the patient back to the OR and redo the patch angioplasty.
So, Ara, what are some of the other complications from carotid surgery?
So some of the local complications are hematomas, wound infections, nerve injuries. The most common nerves injured are the vagus nerve, the hypoglossal nerve, and the marginal mandibular nerve. But there's some debate whether the vagus is the common or the hypoglossal nerve is the most common. As for the systemic complications, the most common one is MI post-op, strokes, contrast-induced nephropathy, renal failure, and death.
There are some other complications that we should talk about. One of them, is cerebral hyperperfusion syndrome, and the risk factors for patients that develop this condition are preoperative stroke, high-grade chronic ipsilateral stenosis of over 90%, chronic cerebral ischemia, perioperative hypertension, and contralateral carotid occlusion. And the concept behind this is that when you increase the flow to the brain that has been chronically ischemic, you get this intracranial hypertension that can lead to intracranial hemorrhage and devastating consequences. These patients usually present 4 to 6 days after surgery with headaches. Some of the other things they can present with is seizures, hypertension, and intracranial hemorrhage presenting as a stroke. The management is to get an immediate CT head to rule out intracranial hemorrhage. These patients are typically admitted to the intensive care units, and they require immediate control of the high blood pressure and anti-seizure prophylaxis. Another thing I'd like to mention is a lot of patients that undergo carotid surgery have hemodynamic instability, and this is related to manipulation of the carotid sinus. The most common findings will be hypotension and bradycardia. Intra-op, you can prevent this by injecting the carotid sinus with 1% lidocaine. Postoperative, these patients are monitored in the unit. They require medication to either bring their pressures up or control their heart rate. That's it for our second episode. I hope you guys enjoyed this episode and learned a little bit about atherosclerotic carotid artery disease. One of the comments we got from our first episode was it'll be nice to give you guys some fun facts. So here's a fun fact about vascular surgery. Albert Einstein died from a ruptured AAA. If you guys like this podcast, do subscribe to our channel to get the next episode as soon as it's released. Also, do leave us comments and suggestions so we can improve this podcast for you.